RPP Proxy and the Perspective of Cardiac Mechanical Loading, either stroke Part 1, number 1581, BPT 117, March 26, 2026, Gerald C. EclaireMD Foundation, Category Stroke, CVD. Cardiovascular Mechanics. Introduction. In this analysis, I examined two independent datasets of cardiac mechanical workload using the rate pressure product RPP. The first dataset covers a 9-year period from 2018 through to 102.6, representing my long-term baseline cardiovascular behavior. The second dataset covers an 18-month period, including 9 months prior to my stroke and 9 months after the stroke. The purpose of this comparison is to determine whether cardiac mechanical loading exhibited any identifiable pattern related to the stroke event and whether RPP provides insight beyond heart rate alone. Particularly for seniors, RPP is defined as RPP equals HR asterisk SBP 100, where HR represents heart rate and SBP represents systolic blood pressure. Division by 100 is simply a scaling adjustment that converts the numerical values into a medical convenient double-digit range. For easier longitudinal comparison, this scaling does not change the underlying physical meaning of the variable. From a biophysical perspective, RPP represents a proxy for cardiac mechanical workload, reflecting the combined effect of pumping frequency HR and blood pressure assistance SBP. Mechanical meaning of from the viewpoint of mechanics, the heart functions as a cyclic pump. Each cardiac contraction must generate sufficient force to overcome arterial pressure and maintain blood circulation. The workload of the heart, therefore, depends on two major factors. 1. The frequency of contraction, heart rate or HR. 2. The blood pressure load against which the heart must pump, systolic blood pressure or SBP. In simplified mechanical terms, workload per unit time is related to force times cycle frequency. SBP represents the pressure load force component, while HR represents the cyclic rate component or cycle frequency. When these two factors are multiplied, the result often provides a useful approximation of myocardial oxygen demand and cardiac workload intensity. Therefore, RPP can be viewed as an output strain variable reflecting the mechanical demand placed on the cardiovascular system. Characteristics of my 8-year dataset. The 8-year dataset shows an RPP range between approximately 58.7 and 70.5, with an average value of 64.66 over this long observation period. The RPP values fluctuate within a relatively narrow band of approximately 12 units. Most of the values lie between 62 and 68. Such a pattern is consistent with a stable viscoelastic system in which the load fluctuates but remains within a controlled envelope. The absence of monotonic increase indicates that long-term cardiac mechanical workload has remained relatively stable despite aging and lifestyle variations. This dataset therefore provides a baseline description of my natural cardiovascular strain behavior. My 8-year stable RPP means my heart workload has stayed stable and my cardiovascular system has been operating in a stable zone. This is a good sign. However, RPP alone cannot prove vascular elasticity is fully normal, because elasticity is more directly reflected by pulse pressure. PP equals SBP dBp. A stable RPP suggests stable cardiac load, while PP SBP dBp is needed to judge vessel stiffness. Characteristics of my recent 18-month dataset. The 18-month dataset covers the period surrounding my stroke event on June 21, 2025, including 9 months prior to stroke and 9 months following stroke. During this interval, RPP ranges between approximately 60.96 and 73.99, with an average value of 68.35. The most important feature of this curve is a peak near the time of the stroke, followed by a decline toward about 63 during the recovery period. This shows that RPP also reflects the stroke event, with a temporary increase in cardiac workload around the stroke time. This statement is reasonable and scientifically acceptable, as long as the RPP peak occurs close to the stroke date and is higher than nearby values. Compared to my 8-year dataset, the average RPP level in this 18-month window is modestly higher by approximately 3.69 units, representing an increase of about 5.7%. However, the magnitude of variation remains similar to the long-term oscillation band observed previously. The peak value of approximately 74 is only slightly above the historical upper range of approximately 70.5. This indicates that the stroke period elevation of RPP is not dramatically outside the system's prior variability envelope. More importantly, after the stroke event, RPP values decline toward the baseline region near 63 to 65, suggesting that the cardiovascular system retains the ability to regulate mechanical workload after disturbance. Key insight: heart rate HR alone does not capture full mechanical loading. One particularly important observation from my 18-month dataset is that heart rate alone remained relatively stable throughout the observation period. However, the product of heart rate and systolic blood pressure reached its highest value near the stroke window. This indicates that mechanical loading increased primarily due to interaction effects between heart rate and blood pressure rather than changes in heart rate alone. Because RPP is a multiplicative structure, small changes in SBP can significantly amplify total workload even when HR remains relatively constant. This shows the amplification effect of the arithmetic operation of multiplication compared with addition. Therefore, heart rate alone cannot represent a full mechanical burden on the cardiovascular system. Blood pressure load plays a critical role in determining myocardial energy demand. Relationship to the TSI triggering sensitivity index concept. The findings from these two RPP curves support the broader concept underlying the TSI model. RPP includes only two interacting components, heart rate and systolic pressure. However, cardiovascular and stroke risk are influenced by multiple interacting factors, including arterial stiffness, pulse pressure, mean arterial pressure, and long-term vascular damage from diabetes. TSI incorporates these three input stress components through multiplicative interaction, capturing a wider range of system influence and providing deeper insight, especially for both stroke and CVD. RPP may therefore be considered a partial projection of system strain, while TSI represents a more comprehensive multidimensional strain structure. In other words, TSI serves as a primary proxy, while RPP serves as a secondary proxy for the risk level of stroke, CVD, and even dementia. Importance of heart rate in seniors and its relevance to this study. Heart rate HR is a fundamental physiological signal reflecting how often the heart pumps blood to supply oxygen and nutrients to the body. In seniors, cardiovascular adaptive capacity gradually declines, making heart rate a more sensitive indicator of system stability. With aging, arteries tend to stiffen, which often increases systolic blood pressure SBP. Higher SBP raises the mechanical load that heart must overcome during each contraction. Therefore, the interaction between heart rate HR and systolic blood pressure SBP becomes increasingly important in evaluating cardiac workload. In this study, heart rate contributes to the rate pressure product RPP. RPP equals HRX SBP 100. This multiplicative structure captures the combined effect of pumping frequency HR and pressure load SBP. Either factor alone does not fully represent cardiac mechanical demand, but together they provide a more meaningful approximation of myocardial workload. In my 18-month dataset, heart rate alone remained relatively stable before and after the stroke event. However, when combined with SBP, RPP reached its highest value near the stroke period. This suggests that heart rate alone does not fully reveal cardiovascular stress, while the interaction between HR and SBP better reflects system strain. This observation supports the broader concept of the mortality disease risk of triggering sensitivity index TSI, which extends the multiplicative structure by including additional physiological factors such as pulse pressure, SBP, DBP, and diabetes consequences through glucose. These additional variables allow TSI to capture a wider range of influences affecting both macrovascular and microvascular circulation. In summary, heart rate remains an important physiologic variable in seniors, but its greatest value emerges when analyzed together with systolic blood pressure through multiplicative interaction. This relationship supports the use of RPP as a secondary mechanical workload indicator and TSI as a primary and comprehensive multidimensional strain proxy for stroke, CVD, and dementia risk. In younger patients, the pumping frequency HR is often the primary driver of stress during exertion. However, in seniors, due to arterial stiffening, the pressure load SBP becomes the dominant stressor. My data perfectly illustrates this shift. In cardiovascular mechanics, therefore, I explain that aging reduces cardiovascular adaptability, making HR more sensitive but only when interpreted together with SBP. Viscoplastic energy VMT analysis results 9-year CAS of energy contribution ratios, PP equals 35%, MAP equals 32%, EAG equals 33%, pivot point equals 99% in 200 to 1,500 18-month CAS of energy contribution ratios. PP equals 34%. MAP equals 34%. E equals 32%. Pivot point equals 44% in June 2025. The three energy components are very evenly distributed, each contributing about 1/3 of the total VMT energy. This balanced distribution indicates that vascular pulsatile load PP, average pressure load NAP, and metabolic load EAG exert comparable influence on the overall strain state represented by RPP. Such a near-equal energy partition is uncommon in biomedical systems, which are often dominated by a single major factor. In this study, the VMT system shows a balanced triad structure: vascular pulsatile load PP, steady pressure load, MAP, metabolic load EAG. These three factors act together as a coupled mechanical system rather than as independent variables. This implies that stroke risk is not driven solely by hypertension or solely by glucose, but by the interaction between pressure dynamics and metabolic damage accumulated over time. The pivot time point occurs near the stroke event of June 21, 2025. This turning point reflects a structural change in the strain-stress relationship of the physiological system. Because the pivot aligns closely with the real clinical event timing, it suggests that the system experienced a structural transition similar to material fatigue approaching a yield point or reaching an instability threshold in nonlinear dynamics. This observation supports the concept that stroke is not a sudden random event, but the result of gradual accumulation of strain energy followed by a triggering condition. Although RPP serves as a secondary stroke proxy and is less comprehensive than the primary proxy TSI, the signal pattern remains clear and directionally consistent with the TSI findings. This agreement strengthens the mechanical interpretation of stroke risk behavior, particularly the validity of the TSI proxy. This is Part 1.